know that we've been sharing work and developing themes throughout the Dementia Fellowship Programme and as we bring the network together. And I thought I'd share some little bits about family carers of people with dementia, because that seems to be a theme in terms of much of what we were doing. And there's a long title that's about quality of life that you have on your sheets there, but I kind of couldn't fit all of those words into this little into this slide. So I boiled it down to family carers being indispensable and invaluable, and that's absolutely true. It's entirely true that they are absolutely indispensable. I thought I'd share some figures from some work that I've been doing recently with the World Health Organization as we've been developing the global action plans for dementia. We've been looking at the contributions that that countries make, but also that carers make worldwide. So I thought I'd start off by talking about that. Entirely indispensable. Without family carers, the whole system that we set up, wherever we might set it up in the world to help people with dementia, would essentially break down immediately. And invaluable. Invaluable sounds a little bit, but it's not the same as worthless. It means that it's priceless. They are absolutely priceless. They are invaluable in that the amount of time, energy and effort, if you were to monetize that people provide as family carers is remarkable and pivotal. And again, so to share some figures about that. And these are figures that you see, that you've seen often, but I really rather like this slide that builds here. The darker bits, if you see where we start here, then you'll see the world getting older in front of your eyes there, in terms of the darker bits being those places where 30% or more of the population are over the age of 60. So there's remarkable population ageing going on. And we think about that, that's remarkable population ageing of older people in general, but also that means that of the need for carers for people as well, not only people with dementia, but people with the complex multimorbidity that exists in older people. And we know about the Global Public Health Challenge of Dementia. You've heard these figures before, but these are ones that really do look at an international level here. So you've got a new case every 3 seconds, 10 million new cases per year, 50 people worldwide now, set to triple by 2050. And the majority of people who will develop dementia already, as well as in the future, will be from low and middle income countries. This kind of reminds us that this issue of who does what, who cares for who, is one that transcends different economies. So here we have low income, low and middle income, low to middle income countries, upper middle income countries, and high income countries. And you'll see right across the board you have increases in the numbers of people with dementia. You have particular increases in low and middle income countries of people with dementia, the numbers of people with dementia. And so, and if you look at who pays for what, then the more you go down through these economies, the more care falls on informal and family carers of people with dementia. So here we have that graphically represented. We have the increase from 18 billion in 2018, now it's $1 trillion illness, dementia, and it'll be a $2 trillion illness in just 20 odd years. So, you know, really major costs, and it then brings you to ask the question: what is driving those costs? Well, the pinky bit at the top here, that is what family carers contribute to the mix. So these are spouses, often partners of individuals, or the adult children of individuals providing care. And you'll see that, you know, in every country, in every income group of countries, it's a substantial amount that is contributed. More in lower and lower middle income countries than in high income countries, but still in high income countries, it's a lot. And the vast amount of costs of healthcare and social care are in high and middle income countries. So this is what informal care does, and that's much more than half the costs of dementia. It's much more than half the workforce of dementia, and so it is absolutely vital that if we're thinking strategically, if we're thinking how we manage the challenges of dementia, then we need to be thinking of the family carers as being the largest and most important part of the workforce that we have to be able to help and manage people, and they are essentially the most valuable player on the team in terms of supporting people with dementia. And I'm going to be talking, and we have people who care, who can be actually from families. They're sometimes called informal carers. That's often seen as a term that seems to kind of diminish the work that's done by families, but that's often used in the scientific literature. And there's paid carers, which are sometimes called formal carers. And of course, if you look into who makes up the family carer group, it is same generation, or sometimes the next generation carers, so same or the next generation carers, and they could be, and one of the other determinants of the extent to which there is a particular call on that carer in terms of time, and a particular impact on the carer in terms of burden, is often determined by whether people are living with that person or not, so co-resident or non-co-resident. From the UK, as I said, the National Dementia Strategy calls carers the most important resource available for people with dementia, and that's just true. About 600,000 family carers provided £8 billion worth of care in the UK. Absolutely vital determinant of positive outcomes. So for example, if you have a co-resident carer, you're 20 times less likely to make a transition from being in your own home to being in a nursing home, controlling for all other factors. Doesn't mean that there aren't some people that go into nursing homes, but that's an immense protective effect of co-resident carers, of family carers, often at tremendous cost to those family carers, of course. So you have high levels of burden, you have high levels of, there are both positive and negative things that people get from carers, caring for people with dementia, and sometimes the positive things are not remembered in the same way as the negative ones are talked about. However, and what we see here is that it basically affects, being a family carer affects plans, expectations, it impacts on valued aspects of life for that carer as well as the person with dementia. As I said, for many there's a satisfaction to be derived, but there's also good data out there that being a family carer can cause problems with physical health, with your psychological health, and certainly with your financial health as well. It's costly to those individuals. It may be a cost that individuals are entirely happy to pay physically, psychologically, and financially, but there is a cost that's there. Family carers, people with dementia have more anxiety and stress. There is good evidence to suggest that it is more complicated and more impactful looking after someone who's got dementia than looking after somebody who's got another chronic condition, even with the same level of physical dependency. And that's because of the particular challenges of the lack of insight in dementia at times, but also of the behavioural and psychiatric symptoms that can sometimes happen in dementia. Very important to remember that caring in dementia is not a fixed set of experiences. It's absolutely not just about the hands-on care, and that because dementia's caring, a progressive illness rather, caring for someone with dementia has been likened by some sociological writers and gerontological writers as actually being a career. It develops, and you develop in that career. And all the dementia strategies that exist across the world, they all stress the vital importance of supporting carers for people with dementia. And research can be helpful in doing that. We need to know how best to support carers. And carer research falls into these four groups. We can quantify the numbers of carers, and we've shared a little bit of information about that. We can also quantify the burden and the impacts on carers. We need to understand that role of caring, and so I've showed you some of the stuff that's out there in terms of trying to understand what those impacts are and the career of carers. In terms of integrating, we need integrated approaches that actually, if we're helping a person with dementia, probably one of the best and most important things we can do to help a person with dementia is to help the family carer of that person with dementia. And it may well be that by helping the person with dementia, we may help or harm the carer of that individual. And so when we're intervening, and there are a number of psychosocial and other interventions that have been developed, some really interesting work from UCL called the START program that seems to have really positive effects on carers, that essentially gives carers a start to knowing how to care well and to manage better with carers. But we need to think about those interventions and the impacts they have on carers of people with dementia. So we're interested if we're, at the most simple, if you give people a drug for dementia, does that help the carers? If you improve people's cognition, does that help carers? If you give somebody a psychosocial intervention to decrease agitation, is that useful for carers? If you give carers their carer support package in order to try and help them to support the person with dementia, then you need to be thinking about outcomes that are not only in the person with dementia, but also in the carers. And hitherto, there hasn't been an instrument that is specific to the experience of caring for someone with dementia that measures the quality of life, the quality of life in the specific condition of being in dementia. And there's lots of measures of health-related quality of life because we want to find out whether our interventions are beneficial to people's quality of life or not. We want to be able to describe whether quality of life changes when certain things happen. And the general measures of quality of life that we have are quite non-specific, so they miss out on lots of what's important in dementia. And there have been some instruments that have been generated for dementia, like carer burden scales, but they focus almost exclusively on the downside of caring. And they were generally produced quite a long time ago and don't necessarily meet the criteria for working well. And so we were funded by the Alzheimer's Society to create a new instrument called CDEMQUAL, which is all about measuring the outcomes of carers. What I'll do here is just show you it. I'll take you very briefly through the development phase, and there's going to be lots of words here. I'll make sure that you're sent these slides, but I just want to focus on 2 or 3 of the kind of conceptual frameworks that we've generated as we went through, and to give you an idea of the process that we've been through. So we're trying to develop CDEMQUAL, a condition-specific questionnaire to measure quality of life for people with dementia. It's a 7-stage process over a 30-month period. We've finished the study now, and we've developed a questionnaire that we're really very pleased with in terms of its performance and its ability to measure what we wish to do. We started off by generating new information on for a conceptual framework to be able to understand what it was that made for good and bad carer quality of life in dementia. So we carried out in-depth individual interviews with family carers and staff. These were audio recorded, transcribed, and these start to help us to develop the structure and the framework of our questionnaire, but also the items within our questionnaire. And we got 3 overarching categories. The first one was about the person with dementia in terms of the relationship that person had with the person with dementia, change in that person with dementia, and the demands of caregiving. And you would imagine those things would be things that you would need to look at. A second is more how the carer appraises those things and how they appraise the impacts of that. So that's all about personal freedoms. Do you do what you want to do? The degree to which people are able to accept the caring role. The fact that some people find positive meaning in caring. There's carer health and expectations for the future in that category. And in the third category, we think about the external world and what the external world is doing to help support carers. And so that's the carer's evaluation of the support that's received, the weight of the responsibility and the extent to which that individual is felt to be responsible. It's because we know that one of the things about family carers is that the caring role, even in large families, tends to fall on one individual, and that tends to be a female individual, most usually a wife, but often a next generation female supporter. So family and social networks, the fact of whether there's role conflict that comes out becomes very important. So we carried out systematic reviews also, where we looked at all published studies and identified the factors that are out there associated with quality of life. We did a second systematic review where we looked to see what instruments were out there to be able to see how people are doing it at the moment, and we found that there were no good measures. We wanted to be absolutely sure that we weren't reinventing a wheel, and we weren't. We then started developing our measure, and we came up with 7 themes around which we developed the measure, which included those qualitative ones that we had that. We then basically generated questions, and we ended up with a big long set of questions, 77 questions that we took out to 25 family carers in Sussex and in North London. And we tried to work out which ones worked and which ones didn't work. And that was then reduced, once we had our first look at it, to 52 questions for preliminary field testing. And in our second stage of field testing, we went out to a new sample of 122 carers, split between co-resident and non-co-resident carers, split between Sussex and North London, so that we had diversity in terms of ethnicity and urban and rural, and also in socio-demographic states. And we went out and we tested those 50-odd questions on those people, and we then boiled it down again. We take a look at which questions worked and which ones didn't, and we finally went out to a further 300 carers across Sussex and North London again to test a final questionnaire, and that's what we ended up doing. So a final questionnaire, 300 carers, CDEM alongside a whole lot of extra instruments to see what we found. And this is what we found, essentially. So we were able to generate an instrument that worked, and what we found was that the instrument that we had, that higher, so better quality of life, as measured by CDEM, was associated with less burden, with better general health, with less anxiety and depression, with greater personal well-being, with better quality of life of the person with dementia, and that's very interesting. So that we see a positive, you would perhaps expect this, but we've not seen this in many other studies because they haven't been, as good at measuring quality of life as we would have wanted them to be. But we see that one of the major determinants of the quality of life of the person with dementia is the carer's quality of life, and vice versa. Better quality of life in the quality of life of the person with dementia, and fewer neuropsychiatric symptoms, confirming that we know that that's a problem. But what we've ended up with is an instrument, and here, this is what it looks like. This is the instructions at the top of it. We take various questions, we rate them on a 5-point scale, and we have 30-odd questions. Here they are. I don't expect you to read this, I'm not providing you with that. What we have is something that's absolutely ready now to be put into evaluations of any intervention that we might have, from a drug intervention to a psychotherapeutic intervention to an educational intervention to a social intervention, that will capture whether or not that intervention has helped or harmed the carer in terms of quality of life. We can also use this instrument to be able to see whether there are variations, for example, in the quality of life of carers of people with dementia between different areas or places or services, so we can describe things there, and we can use it to further understand and to develop better ways of supporting carers of people with dementia. So we're right at the beginning of a process here in terms of the instruments that we have, but one that is interesting. So 5 constructs: meeting personal needs, carer well-being, confidence in the future, feeling supported, carer-patient relationships. Those are things that seem to determine positive or positive outcomes. It's a 30-question questionnaire. It's out there, able and willing to be used. And I've used this slide before, but I like it very much because it reminds me that you can't do good dementia research without focusing not only on the person with dementia, but also the family carers of people with dementia, in the same way as you can't provide good dementia care without focusing not only on the person with dementia, but also on the family carers. So that makes us this person at the top here. So thank you very much for that. The most important question is, are you feeling sleepy? Are you feeling calm after? You notice there was a very calm voice that I put on there. So that was supposed deliberately to be unstimulated. This bit is deliberately supposed to be stimulated. So I'm going to turn that
if
off.
anybody had any questions, actually, should we just, we've got 2 minutes, just